Good afternoon. Welcome to another KVDL webinar. I'm Dr. Katie Klenda. I am Section Head of Client Services and part of the outreach team here at the KVDL. First, I'd like to thank you all for joining us here today, especially those who are new attendees. We do have a few housekeeping items to go over before we get started. First is this webinar is scheduled for a 30 to 45 minute presentation, followed by a question and answer session. If you have questions, please feel free to put those in chat or use the hands up option, which is anonymous. If we run out of time to go through those questions, there will be information for contact information for our speaker at the end, so please feel free to reach out. If you stay with us for the entire webinar, you are eligible for 1 hour of CE. Please expect those to be emailed out in about 2 to 3 weeks. We will also reach out with a survey in the next few days. We are looking for any feedback. Please let us know what we're doing well, some things we can improve on, and give us your ideas of future topics. Your feedback is extremely important to us, and now it is my pleasure to introduce our speaker today. Dr. Janine Seetahal has provided oversight and leadership for the KVDL Rabies Laboratory as the section head since 2022. Prior to this, she spent many years as a government veterinarian in Trinidad and Tobago, gaining essential knowledge and skills in regulatory veterinary medicine. She obtained her Doctor of Veterinary Medicine degree from the University of the West Indies, after which her interest in public health led her to pursue a Master's of Public Health and postgraduate research on the epidemiology of rabies in the Caribbean. This combination of training and experiences allowed her to effectively guide policies and protocols on rabies control and prevention. In her current role, Dr. Seetahal aims to promote the implementation of evidence-based One Health contextualized programs and policies for rabies prevention and control on the global scale and contribute to the progression of diagnostic and medical advancements in the field of rabies.
Thank you. All right. So, well, hello out there. So I'm going to talk about rabies in the context of the prevalence across species with an emphasis on shared risks and shared responsibilities between the veterinary and medical fraternities. So just a little bit about this slide. I asked AI to create a picture based on the topic, rabies across species, and it definitely did not disappoint. So it created this very colorful, dramatic scene, which I think the sheer complexity of it reflects the topic of rabies pretty well. So in this presentation, this is just to give a little sneak peek of the key points that I plan to review in this presentation, which is what both veterinarians and physicians need to know to keep their patients, their clients, and themselves safe. So my hope at the end of this presentation is that the take-home points for you would be when to act, what to do, and who to call. So let's start with the disease itself. Rabies is an acute progressive encephalitis, which has been known for centuries. The correlation between the bite of a dog and a clinically dramatic fatal illness was recognized across many cultures. So the disease rabies is caused by viruses of the Lyssa virus genus. In Greek mythology, Lyssa was the goddess of rage and fury. And in fact, the word rabies itself means to do violence. There are currently about 20 to 22 recognized and proposed Lyssa viruses worldwide. And although there are numerous non-rabies Lyssa viruses, which are associated with bats in the old world, the only known Lyssa virus in the new world is rabies virus. So rabies virus is the type species of the Lyssa virus genus, and it poses the most significant public health threat among all Lyssa viruses. It is a bullet-shaped virus with an RNA genome, and it encodes for 5 viral proteins. Rabies exists in 2 natural cycles, the urban cycle and the wild cycle. The urban cycle circulates the canine variant and is perpetuated by dog-to-dog transmission. The wild cycle, or the sylvatic cycles, involves different wildlife reservoirs with specific variants occurring in different species. These variants are usually transmitted and maintained between members of the same species, same animal species, so dog to dog, bat to bat, but they can be transmitted to any susceptible mammal by spillover. So any variant can infect any mammal and cause disease. Rabies viruses are present in over 150 countries worldwide, and they are maintained in over 60 animal reservoir species in distinct geographic regions. And generally, in areas where dog rabies has been controlled, wildlife rabies is usually more prominently noted. So still at the global level now, with a survival rate of less than 0.1%, rabies is thought to be the cause of at least 59,000 deaths worldwide every year, with 99% of these resulting from dog bites. Most deaths occur in Africa and Asia, where dog-transmitted rabies is still endemic, as compared to other areas where dog rabies has been eliminated or is well controlled, such as in North America and parts of Latin America and Europe. So in the United States, between 3,500 to 5,000 animal rabies cases are reported to the CDC every year, and the majority of these are from wildlife. Rabies prevention costs more than $500 million every year, with a large part of this cost due to post-exposure prophylactic treatment, with about 100,000 people in the US administered PEP each year at an average cost of $3,800. So you can definitely see that this is still a significant financial burden as well here in the US. So looking at specific case data for the US, animal rabies cases has been nationally notifiable since 1944. And since then, with the introduction of animal control laws, so leash laws, and vaccination programs, domestic animal cases have declined significantly over the last several decades. And this led to the elimination of canine variant rabies in 2007. So as we've seen elsewhere, as dog cases decline, rabies in wildlife becomes more apparent. So the slide looks at the picture of rabies in wild animals. And these have accounted for over 90% of animal rabies cases since 1991. The main wildlife reservoir species in the US, you can see here on the map to your right, are bats across the US, raccoons more on the eastern coast, skunks, foxes, and the mongoose in Puerto Rico. Cats are currently the most commonly reported rabid domestic animal in the US, with cases in cats outnumbering dogs since 1990. And this is really a reflection of the spillover of wildlife rabies variants due to the natural behavior of cats. They are hunters. They like to roam outdoors by themselves, unsupervised, and they also may have lower vaccination rates than dogs. So people tend to vaccinate dogs more than cats. Cat exposures also account for more post-exposure prophylactic administrations to people than exposures to other species. So as we saw with domestic animal cases, similarly, the dominant rabbit species for wildlife have also evolved over time. So for instance, raccoons were the most frequently reported rabbit animal in the US in 2019, but from 2021 onwards, bats were found to be the most frequently reported rabbit animal. In Kansas, skunks and bats are the most commonly positive wildlife species, with notable skunk variant spillover into domestic animals, particularly cats. Human rabies in the US. Human rabies deaths in the US are rare, but typically occur in people who do not seek prompt medical care after an exposure. We generally see an average of 1 to 3 cases per year, so less than 10 for sure. And this has been a significant decrease from 30 to 50 cases that were seen in the 40s. Bat exposures are the leading source of human rabies cases, and they've been responsible for about 83% of cases over the last 24 years. While the exact reason for not seeking care is often unclear, a lack of awareness of the risk of rabies is thought to be an important factor. And most cases identified on variant typing have had no history of bat contact. and this is likely due to the inapparent nature of bites by these very small animals. When it comes to transmission of rabies, for transmission to occur, the virus must be inoculated through breaks in the skin or contact with mucous membranes. So there usually has to be a direct contact between the rabid animal and susceptible host, which is typically a bite, but it can also be as inconspicuous as a scratch. For transmission, there have been specific circumstances which have been extremely rare, where viral transmission can occur through aerosolization of the virus. So there have been 4 human cases reported. 2 have been reported on account of lab exposures, so in the process of vaccine production, tissue homogenization. And there have been also 2 suspected to be acquired from contact in a cave with very high densities of bats. There have been also a few reports of splash or wound contamination with infected material. So for instance, the butchering of rabid animals, persons with open wounds, contact with neurological tissues, persons who, farmers who reach into the mouths of their animal, so their cow, and get exposed through lesions on their hands. There have been cases of those, and the only instances of confirmed human-to-human transmission of rabies, though, have been organ transplants from misdiagnosed donors. So after the virus enters the body, it travels through the nerves from the infection site to the CNS, and this is relatively slowly. At this time, there's no signs of rabies, there's no signs of clinical disease. When it reaches the brain, though, there's rapid replication, and the virus is transported to non-nervous tissues at a significantly faster rate. So the end of the cycle of infection is when the virus is excreted in the saliva, so viral shedding. And this can be intermittent, and it can vary over the course of the illness. There are many variables associated with infection. So the incubation of rabies itself can vary significantly. In humans, it's typically 1 to 3 months in the majority of cases, but there have been reports up to several years. So how do we identify a rabies suspect? Rabies can manifest as furious or paralytic rabies, and this is dependent on the type of symptoms that predominate. So cerebral symptoms predominate in furious rabies, and spinal cord symptoms predominate and are more pronounced in paralytic rabies. In paralytic rabies, there is also more inflammation pronounced in the brainstem. I have some little slides here to show that. Once rabies symptoms appear, the disease is invariably fatal. So initial clinical signs for rabies are usually non-specific, and this is in the prodromal phase, and they can include mild behavioral changes, lethargy in animals, in humans, flu-like symptoms. This usually lasts up to 1 week, a few days to 1 week. And then we move on to the neurological phase, which is characterized by either excitatory or paralytic symptoms. So the furious phase, characterized by aggression, hyperactivity, and generally exaggerated responses to stimuli. The paralytic phase is characterized by weakness and progression of paralysis from the periphery, usually upwards towards the head and neck. The paralytic form also tends to have a more prolonged clinical phase, and this can be up to 14 days on average, as compared to about 5 days with the furious form. It is very important when we look at clinical signs in animals to note that the clinical presentation of rabies cases in animals may not be uniform, and they can have a wide variation between species and even individual animals. So given these variations, the clinical diagnosis of rabies in animals is often difficult and often unreliable. Therefore, laboratory testing of clinical suspect animals is essential for confirmation. Here we go. So what does testing involve? So when we're looking at animal diagnosis, the basis of animal diagnosis is a post-mortem identification of virus in the brain. So testing is usually centered around clinically suspect animals, animals involved in human exposures, and also testing is done for wildlife surveillance efforts. There's no approved antemortem test for animals. In contrast, for humans, although antemortem testing is conducted, there's no single test that is considered adequate, and a diagnostic strategy is based upon several tests, multiple sample types collected at multiple time points. So importantly to note here is that a negative antemortem test in humans does not rule out rabies, and the negative must be confirmed by post-mortem testing. So different diagnostic tests target different components of the virus and therefore have different utility. This slide just gives a broad overview of the different types of tests that are utilized for rabies and the various targets. So antigen, antibody, nucleic acid, PCR, and virus. So here at KVDL, we conduct the direct fluorescent antibody test, or the DFA test. And this is based on detection of rabies virus proteins in the brain of a suspect animal. This test has almost 100% sensitivity and specificity and has been the gold standard test for rabies since the 1950s. When it comes to sample submission, keeping in mind that the brain is required for testing animals, samples submitted for testing should be euthanized in such a way as to maintain the integrity of the brain. So specimen submissions for small animals, the whole carcass, so for instance with bats, the whole carcass can be sent in. For larger animals, only the head or even the entire brain can be submitted. Chemical fixation should be avoided as this can preclude reliable testing. And also to facilitate prompt testing, specimens should be stored and shipped under refrigeration conditions, preferably. And this is mainly because the need to thaw frozen specimens may delay testing. However, if shipping is expected to be prolonged or there's some issues anticipated with how long it takes to get to the lab, in those instances, freezing can be an option to maintain sample integrity. So for more information on the sample submission, you can find some further guidelines on our website. I've put a QR code there that goes to our submission form. And just to stress on the fact that given that testing is often used to determine the need for post-exposure prophylactic treatment in humans, it is essential to fill in all the relevant fields on this form. So there's some information here that are used by our public health partners to determine how quickly PEP is needed and to contact anybody that has been exposed. For testing, a full cross-section of fresh brain stem and cerebellum are needed for diagnostic testing. So if these samples are not submitted, rabies cannot be conclusively ruled out, even if whatever sample that was submitted is tested and yields a negative. And this is due to the possibility for unilateral spread of the virus up the brainstem into the brain. And this is especially true when it comes to testing large animals. So test results will be reported as positive if rabies nuclear protein antigen is visualized. And this is visualized as an apple green fluorescent area in the brain. So on this slide, you can see an example of that. It's quite pretty. The test itself takes about 4 hours. So the turnaround time can be within the same day, depending on the submission conditions of the sample and the time of day that the sample was submitted. So when it comes to human testing for rabies, the brain, of course, is not available before death. So other samples such as saliva, serum, spinal fluid, skin biopsies need to be used. However, the test sensitivity varies according to numerous factors, such as the clinical stage of the disease, the immune response of the host, as well as viral intermittent shedding. So again, several tests on multiple samples over multiple time points is needed to increase the diagnostic sensitivity. And again, bear in mind, a negative result does not rule out rabies for antemortem testing in humans, and this needs to be confirmed on postmortem. So when it comes to rabies legislation, there's federal, there's state, and there can be local regulations as well. So in the US, animal rabies is nationally notifiable. Notification is required within specific time frames, and this is based on the epidemiological significance of the result. Rabies case definition is defined by the CST, which is the Council of State and Territorial Epidemiologists, and this does change over time to reflect diagnostic advances. Import control regulations specific to rabies are implemented by the CDC, and they are in place to prevent the reintroduction of canine variant to the US. So as I mentioned, this was eliminated in 2007. And to put things in perspective, the importation of rabid dogs have occurred at least 4 times within the last decade, with one event also occurring in Kansas in 2019. And this cost the public health sector over $200,000 in personnel time and resources. So you can see just one animal, one little rabid animal can have a significant impact. So despite importation and entry requirements for visiting animals, not all states do have state-level requirements for rabies vaccination of resident animals. And in fact, 11 states do not require mandatory vaccination of dogs and cats. But within these states, local jurisdictions and within the cities, they may impose specific laws and regulations. Most states do require rabies vaccination, though, to be conducted either carried out by a veterinarian or under the direct supervision of a licensed veterinarian. In some states where rabies vaccination is a state-level requirement, vaccine exemptions may be allowed under certain medical circumstances. However, to note, this does not exempt the animal from other laws related to rabies, and there may be also specific requirements for confinement and control of the animal. The U.S. National Rabies Surveillance System. So this surveillance system in place in the U.S. for rabies is a laboratory-based system. It consists of about 130 state laboratories that conduct animal rabies testing. And these conduct animal rabies testing submitted by the public, veterinarians. We also have surveillance on the federal side with wildlife, the USDA Wildlife Services. They monitor select areas of the country to identify the spread of wildlife rabies and to document the impacts of an ongoing ORV, which is oral rabies vaccination management actions that is conducted. And these systems all generate information towards a baseline prevalence to guide public health decisions and allow the detection of changes to inform interventions that are necessary. So one such intervention into rabies control, rabies prevention, is vaccination of animals against rabies. So in the US, several modern cell culture animal vaccines are approved and commercially available. And these are protective against all variants of rabies. And although they are officially validated for specific species, they can be used and are effective in most mammalian species. Primary vaccination for domestic animals is generally recommended to start no younger than 3 months. And this is based on the fact that there could be interference by maternal antibodies. The animal's immune system could not be fully developed yet to respond to the vaccine. So those recommendations are in place because of that. So after the first vaccine, it's usually one booster 1 year later, and then every year or 3 years, depending on the duration of immunity indicated by the vaccine manufacturer. Vaccination programs can also be conducted at the level of, at the farm level, to increase herd immunity as compared to individual animals, individual pets. So herd immunity is important in areas where, in endemic areas where there's a high risk of spillover of infections. For instance, in areas where vampire bat rabies predominates, there's a high risk of spillover into livestock because of the feeding habits of the vampire bats. So it's important to increase herd immunity there. In some circumstances, vaccination of individual animals, so individual valuable animals and animals that can potentially have contact with large numbers of people. So show animals, zoological exhibits, these may also be considered. And to just talk a little bit about extra label use of vaccines. So extra label use of vaccines is when these are administered to species that they were not listed on label for. And these should also be considered where applicable, depending on the risk. And I mentioned zoological sample, or zoological species or specimens, they're used there quite frequently. However, it needs to be kept in mind that while this is widely practiced to protect the valuable animal, these species will still not be considered vaccinated from a public health standpoint if there is a human exposure of that animal to a human. Oral rabies vaccination has been used in the United States since the 1990s. And currently there are 16 states distributing oral vaccines for raccoons, and Texas also does bait distribution to foxes and coyotes. Each year, there are about 6.5 million baits distributed to create a zone of containment for raccoon rabies in the eastern states. And this is essentially to try and keep raccoon rabies confined to that area. So I want to talk a little bit about management of animal exposures. So domestic animals can frequently become exposed to rabies, and this is usually through the interactions with wildlife. And the way these cases are managed, it varies according to certain factors, and I'll review some of them here. So factors that can influence the approach to the management of these cases, animals that have been exposed to a rabid animal, include the species and vaccine status of the animal, the time since the exposure, and the ability to confine the animal for a requisite period under required conditions. Okay, so for dogs and cats, if we're looking at an animal with a current vaccination record, if these animals are exposed, they can be boosted and observed for 45 days. This can also be done if early intervention is carried out for animals that are out of date on their vaccine. So if it's not vaccinated, given a booster according to the manufacturer's instructions on the label. So it's not boosted for that year if it's given an annual vaccine. But on the other hand, if you'd like to determine if an animal that is said to be out of date and there's no proof of this, you want to know if that animal is actually vaccinated, we can use something called prospective serological monitoring. And I'll talk a little bit about that. If the animal is not vaccinated, options generally would be euthanasia and or vaccinate and quarantine for a period of 4 months. So this period can be extended in cases where vaccination is delayed, and usually these decisions are made in consultation with your state public health veterinarian. So when it comes to serological prospective serological monitoring, paired serum samples are evaluated for a statistically significant rise in titer, and also the level of the second titer is anticipated to be above 0.5. So if the titer response is deemed to be adequate, so you're looking for the two things, the second titer above a certain level and that rise in titer between the first and the second, if that response is deemed to be adequate, the animal will be held for 45 days under observation. Or if the response is not deemed to be adequate, the animal is considered that it was not vaccinated previously, and the period of observation is then 4 months. So when it comes to post-exposure management for livestock animals, if the animal does not have a current record of vaccination, these need to be evaluated on a case-by-case basis with the possibility of extending 6 months quarantine to the animal. So some states have actually also utilized post-exposure vaccination regimes similar to human protocols, combined with isolation periods to manage animals exposed to rabies. And I think the most documented example of this is in Texas. So when it comes to management of human exposures, there are steps to take both on the human and animal side. So from the human health perspective, wound care is of paramount importance to reduce the risk of rabies. Post-exposure prophylaxis can either be administered immediately or pending the results of rabies testing of the aggressor animal. This decision would be based on consultation with local public health authorities after conducting a risk assessment. So on the veterinary side now, broadly, the options for handling the animal would be euthanize or test and confine and observe. Euthanize and test, or confine and observe, I should say. Immediate euthanasia and testing is generally recommended for animals with clinical signs suggestive of rabies. However, for healthy animals, given that that during disease incubation, the virus will only be present in the saliva for a few days before clinical signs develop, the aggressor animal can be confined and observed for a period of 10 days. And again, this should be decided on in coordination with public health authorities after consideration of case-specific information. So, given the generally long incubation period of rabies, rabies exposures to suspect animals is usually considered a medical urgency, which means that there can be time which will allow for testing or observation to determine if rabies prophylaxis, which is quite expensive as we have established, is actually warranted. So some important points on observation periods. These are only utilized for dogs, cats, and ferrets and are not recommended for wildlife and exotic species. And this is really because the virus shedding periods for these species are largely unknown. If an animal is out of date on a vaccine, after the period of observation, if it's healthy and survives, it can be given a boost at exit out of the observation period. This is generally not recommended. It's very important to not vaccinate the animal upon entry into observation because any possible vaccine reaction can potentially be confused with signs of illness. So ultimately, how exposures are handled should be based on risk assessment, evaluating several factors. So these are listed here, and I will talk about some of them in the following slides. So again, just to touch on a few, the species of the aggressor animal is an important factor. Wild animals, especially those that are not available for testing, are presumed positive. And this is particularly true if the aggressor animal is a known rabies reservoir or has had high positivity rates in that area. And of course, bat exposures in general are considered more risky and requires more intense scrutiny. So again, this is partially due to the limited visibility of a bat bite as compared to larger animals. They have very little teeth and are very tiny. So it should be considered an exposure when direct contact with a bat cannot be confidently ruled out. So for instance, if a person wakes up and there's a bat in their room, they can't confidently rule out that they were bitten or scratched. That's an exposure. If there is a bat found in a room with a small child who cannot voice if that bat had contact with them, if they were bitten or scratched or anything, that's an exposure. So one of the other things to consider, and which is important, is that you need to consider the circumstances of the exposure. So many negative interactions with animals that appear aggressive can also arise from willful or unintentional provocation of the animal. So an animal that is defensive may appear aggressive. If an animal feels trapped or cornered, an injured animal or a mother protecting its young, it may come across as aggressive, but it is not an unprovoked aggression. And it's normal to the circumstances that the animal is put into. So the type of exposure also needs to be considered, of course, when assessing steps that need to be taken with regards to post-exposure treatment. For instance, rabies is 50 times more likely after a bite than a scratch. More extensive, widespread, deep wounds are usually considered more severe exposures, and there's more urgency taken there, as well as the location of the exposure is critically important. So, for instance, bites that occur above the shoulders, the face, and the head, these are considered higher risk than those in the extremities, and in some instances, they may not, public health authorities may not wait for testing and may just go ahead and vaccinate, treat. So when it comes to prevention, rabies is 100% preventable with vaccination before clinical signs. And this can be before or after an exposure to a suspect or a confirmed rabid animal, and again, before clinical signs develop. Occupationally, rabies vaccination is recommended for persons at continuous risk of exposure to the virus, such as vets, wildlife officers, laboratory staff. Pre-exposure vaccination is thought to offer protection from unknown exposures, and it negates the need for rabies immunoglobulin if an exposure does occur. And this is often the most expensive part of the post-exposure prophylaxis. And also it is not as widely available as vaccine. So this is important to note. In 2018, the World Health Organization updated their recommendations from 3 vaccines over the course of 21 days for pre-exposure vaccination of at-risk persons to 2 vaccines over the course of 7 days. And this change was also reviewed by the ACIP, the Advisory Committee on Immunization Practices, in 2022 and adopted. So the ACIP recommendation still indicates rabies antibody titer checks every 6 months and every 2 years for persons who handle live virus and who handle bats. And this is to provide protection from unrecognized exposures and, of course, boosters if the level falls below that 0.5 level. The major change here is for persons in what is now category 3, where the risk is mainly from recognized exposures, and these include veterinarians. So the ACIP now recommends a one-time titer check within 1 to 3 years after the primary series, or a booster dose administered from day 21 up to 3 years after the primary series for this risk category. So looking at post-exposure prophylaxis in humans, so after an exposure, vaccination, of course, is also given as part of the treatment regime, as well as other steps, flushing of the wound and administration of RIG. And these are strategies that are employed to decrease the amount of virus that is available to enter the CNS and initiate an infection. So when it comes to recognized exposures, there are 3 exposure categories that are recognized by WHO, with only categories 2 and 3 warranting treatment. Vaccination after exposure consists of 4 vaccines over the course of 2 weeks for unvaccinated persons, with rabies immunoglobulin only administered in category 3 exposures. So category 3 exposures, just to look at that again, is the most extensive exposures, and it also includes exposures to bats. So there's a difference in how the regime is handled between persons who were vaccinated before and persons who are not vaccinated. So for persons that were previously vaccinated, there is no need for the rabies immunoglobulin administration, which, as I said before, is the most expensive and not always available part of the PEP, which is post-exposure prophylaxis. And also, if PEP is administered to a person that's previously vaccinated and that person has a repeat exposure within 3 months, there's no booster doses required. So rounding up now, I just want to look at rabies education as a tool for prevention and control of rabies. So it has been said that education begins after you leave school, and I think this is an important reminder of the need to keep up to date on information, especially for a disease that evolves constantly. Sometimes it is as simple as making a call to find out more information or pass on vital information to help other practitioners in One Health to protect their patients. So again, that communication between the medical and the veterinary fraternity is essential to make that connection between animals that expose persons, the rabies in animals and rabies, possible rabies exposures in persons. Engaging with the community is also important, is an important One Health action to help prevent further spread. So simple measures as a veterinarian would be like notifying other vet clinics in your area of an animal case that you diagnosed, advocate for local media postings when cases occur, leverage your network, get the word out, help us prevent the spread of this disease. The Global World Rabies Day initiative, this was started in 2007, and it continues to be an effective platform for community outreach, community engagement. It's every year centered around September the 28th, but we don't have to wait for that time. In your routine daily interactions with your patients or your clients, you can also pass on messages that can have some very profound impacts on rabies prevention. And I've given just some examples here of impactful advice that can make a big difference. So vaccinating, informing clients about the need to vaccinate their dogs and cats, not only for the safety of their pets, but that it's important for the safety of their family, not allowing their pets to roam free unsupervised. If this does happen, ensuring that when the animals do come back with, an unknown wound, that there's prompt veterinary attention given to the animal. Of course, if you find a bat in a room where you sleep, it should be important to call your public health official. Also for persons who are traveling, just that recognition that rabies risk may be higher in some countries than others, and the importance of having a medical consult before traveling or even after traveling if there was contact with an animal in a foreign country, just the need and to get that information on the actual risk specific to that geographical location. Also, letting clients know, letting patients know that there's risks involved in keeping wildlife. Don't have them as pets. Avoid feeding or handling them if they're not properly trained. This is especially important to teach children. Don't approach or handle wild animals. Don't approach unfamiliar animals. And observe them from afar. Reporting wild animals that are acting strange helps towards, diagnosing cases. And seeking medical attention, even if not bitten, if it's just a scratch, or if you're unsure about the contact with an animal, it's important to seek medical attention, seek that medical advice. And lastly, modern rabies vaccines. It's really important to let your patients know that these are safe and highly effective when given early, and any delays or even refusal can be fatal. So, it is well known that educating and promoting children as health advocates has significant effects across generations. So as part of our educational drive at the lab here, we partnered with several stakeholders to host our second poster competition for kids in Kansas. And I've just included some details about the poster competition here. The deadline is January 30th, but this will likely be extended. We really want to get the kids engaged and get those entries submitted. So some information about the poster competition here. You can find a link, or you can just search it up on our website to get the information. And with that, I'd just like to thank you for your attention. I provided my email contact and phone contact in case anybody wants to reach out after.